Today's a little bit unusual for me. I'm usually creating chaos in these sorts of venues and getting people doing all sorts of crazy things. At the last ISME we played motivational interviewing cricket and had people bowling statements and bouncing back reflections, and it was chaos. So it's a bit unusual for me to move into not creating chaos and actually speaking. So I've got my safety net here, so if I drop them I'm in all sorts of trouble. It's unusual also and a little daunting to be speaking in front of a room full of people who have a real passion for MI and are interested in changing the way that they work and their services work. And that's perhaps where this idea has come from. So I'm a clinical psychologist and the manager of a psychology department at Ballarat Health Services. And we're in the fairly unusual situation in Australia in that we have 2 motivational interviewing network of trainers in my department, and I'm one of those. And we have quite remarkable executive level support for motivational interviewing in the organisation. So after myself and Rochelle Cairns went to, we've talked before, Joel lit the fire a few years before that, and then he unleashed us and created monsters. But after we did our training for new trainers in Ohio in 2008, we came back and set about training allied health professionals in our organisation, predominantly in outpatient healthcare settings. So we trained people who really don't have a foundation in counselling skills, prosthetists, orthotists. My son's very proud of me that I can say prosthetist. Dietitians, speech pathologists. There were 10 disciplines that participated in our training, and it went over about a 38-week period. So we did a 2-day workshop and we followed it up with 4 one-hour small group coaching sessions. And we had a 1-day forum about 24 weeks into the program. We took 5-minute grabs, audio grabs of those participants prior to the workshop, post the workshop, at week 12 after the coaching sessions, and also at week 24 and at week 38. So we got a good idea of what people were doing and how they changed, and it's starting to sort of have an impact on the organisation, to the point that we have things like one of our prosthetists has come to me and said, I was running some supervision with a student the other day and I was taking an eliciting approach, and I was saying, so this is what is going on for the patient, what do you think you might do next? And interestingly, that's a beautiful way of working with a student. The senior prosthetist stepped in and told him what it was that needed to happen. So we've still got a long way to go. We've got executive support, we've got some key people involved, but there's still not a shared understanding across the organisation. I've also had the experience of people who've been through our training having a really positive impact on the clients that they work with. So I work with eating disordered patients, and I've had them come and say to me, the dietitians here, they're not like the other dietitians I've worked with. They listen. They don't just tell me what to do, they actually listen. And it's really striking the difference that makes in terms of the ability for a person to get the most out of the health system that they're trying to use to be well. So I think we're missing something still. We've got a core group of people who are very engaged with motivational interviewing, but then some of those people will still say things like, well, you should MI them. Or talk to Kylie and she'll tell you how to MI them. Or, I know what to do when I get stuck. And that's where this came from. The Felix the Cat approach to motivational interviewing. And I wonder if part of what we've done where I am is to train people to pull MI out when they get stuck. So for those of you unfamiliar with Felix the Cat, he's been around for a really long time. And I promised my 10-year-old son, who was horrified by the fact that what I'm about to present to you is a presentation, because he's 10 and he likes really, really bright colours and lots of text, and couldn't believe what I was producing. And you're talking to lots of people and that's what you're doing? That it goes, he had a theme song, which is Felix the Cat, the wonderful, wonderful cat. Whenever he gets in a fix, he reaches into his bag of tricks. And I have a sneaking suspicion that we might have created a bit of that And maybe I see some nods, maybe that's just not me. Before I move on, I'd like to recap a little bit about what MI is, the definition of MI. And I guess when I'm asked, I say it's a way of helping people to find their own motivation for change. And that seems to make enough sense to people. But I wanted to take the opportunity now to read out the more technical definition. So this one comes from the 3rd edition of the Motivational Interviewing text by Steve and Bill. And it's a statement that I think is worth really listening to. Motivational interviewing is a collaborative, goal-oriented style of communication with particular attention to the language of change. It is designed to strengthen personal motivation for and commitment to a specific goal by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion. As a healthcare clinician, I hear that as an aspirational statement. That's something that I hope I'm working towards. And in the back of my mind, I have a little sort of running commentary that says, well, isn't that how all healthcare communication should be? And what would it be like if this way of communicating was experienced by all our patients? So I'd like to ask you to take a moment to yourself, and you can close your eyes if you want to, but you don't have to. But I'd like you to consider the following. Think about a healthcare experience that you've had that was a negative one. Take the time to imagine where you were. Think about who was in the room with you, what you were thinking about and what you were worried about, what you thought might happen. And I'm going to pose a few questions to consider. How comfortable did you feel talking to the clinician? How much did you feel your perspective was understood? How much did the interaction feel like a partnership, like you were working together on something? How engaged were you with the direction that the clinician took? How much did you feel your reasons for change were listened to? Who did most of the talking? If there was a plan at the end of the session, how engaged were you in that plan? In 1 or 2 words, or 3 words, 4 words, but keep it short, I'd really like it if a couple of people from the audience would think about throwing to me what your clinician could have done differently that might have moved that towards a more positive interaction.
Ask me what I'd already tried.
Ask me what I've already tried.
Listen to my concerns.
Listen to the concerns. They were all floating around in your head. You were looking for the opportunity to tell someone.
Shut up for a bit.
Hang on, isn't this my session? Aren't I supposed to be telling you? The comment was shut up for a bit.
Acknowledge how I felt.
Acknowledge how I felt, yeah. And I don't know, some of you know that I've had a roller coaster ride with my own healthcare, and the only reason I know that I'm a little nervous today that my heart won't skip a beat is because I'm battery operated and it actually can't. So I've got a pacemaker. So I've actually been through quite some interesting interactions, and one of which was being told by a cardiologist who was concerned about my blood pressure when I was probably about 25. And I got upset about that because I'm a bit invested in my own mortality. And, with the history of heart conditions in my family, it was a little concerning. And so I teared up and I got quite emotional. And he looked at me and he said, "Oh, what? It's not cancer." Pretty sure he wasn't listening to my concerns and he didn't really see things from where I was coming from. Okay, so I'm just going to take a minute or two just to summarise what I think some of the themes of negative interaction are. And as you can see today, I'm having a little bit of a focus on cats. I like cats, but I'm probably a dog person. Maybe the clinician that you were working with had their own agenda and they were pursuing it ruthlessly, with some vigour. They were after a quick session, they were collecting data. Maybe they will focus on something that was either really threatening to you or irrelevant to you. Maybe this whole process of healthcare was just a mystery to you. It felt like someone was trying to get you to do something that you didn't really want to be doing. And it felt like you weren't a part of it. And my particular favourite, so I'm not sure how clear that is. It's pretty clear. For those of you down the back, John's looking pretty pleased with himself. And Garfield says, "You really haven't been paying attention to your life, have you?" Perhaps you felt judged by the person who you were working with. And to relate back to what Stan said this afternoon, there may have been a lack of compassion. So we've given some thought to negative healthcare interactions. What about routine healthcare? So today, my mate Felix is going to be our clinician. What does Felix do on a daily basis as a healthcare professional? Well, we know that most healthcare professionals run multiple 10 to 15 minute sessions. And they assess and they diagnose and they advise and they treat. And then the next session, they assess, they diagnose and they advise and they treat. And I'm a healthcare clinician. I do all those things too. Day after day, it's what's expected of us. We don't have time to chat. And one of the things that came about in my journey to being battery operated was that one of the doctors I worked with said to me, because Ballarat's a small town, I don't know if I mentioned that that's where I'm from, small as in we've got about a catchment area of about 100,000 people, so you know people. So I was getting something sorted, and this doctor said to me, "Oh, Kylie, I've heard your name around the place. What's this thing that you're talking about?" And I said, "Oh, do you mean motivational interviewing?" Yeah, well, what's that? So I gave him my sort of summary statement. Well, it's about helping people find their own motivation for change. Oh yeah, but that takes a lot of time. Training people to do that takes a lot of time and it's expensive. And in a health service like ours, it's thousands of people. And he was quite confronted by that. And I said to him, well, interesting. How effective do you think what we do now is? And he paused. He's pretty bright. How expensive do you think what we do now is for the outcome that we're getting? So there's an argument that people keep doing the same things, going away, coming back, and we keep telling them the same things, they keep going away, not doing it. So I guess, again, that's kind of where my idea came from. So as a clinician, we wander along doing the same thing day in, day out. That is, until we land on our backsides. Or something shakes us up a little bit anyway. And maybe that's that the client's actually not changing. And we've been, clued in enough and we haven't shuffled them around to 5 different people. We're the person that's received the 5th time they've come back and haven't done what we've told them to do. Or maybe the behaviour's escalating. And Sarah, my colleague, will like my language here because we literally get this language in some of our referrals. Maybe the client is argumentative, resistant, in denial, not listening, non-compliant, non-adherent, or perhaps my particular favourite, acopia, as a diagnosis. And when you follow up with the referrer, the language that you hear is, well, they need to change what they're eating because their HbA1cs are an absolute mess. If they end up in hospital another time, it's going to be a child protection or on and on. They need to eat differently because if they carry that weight into surgery, it's just not going to be a good outcome. And a lot of the you'd think that language, like we've read in the MI text, well, you'd think that, the threat of amputation would be enough to, change the way that you do things. And I don't know, and Sarah I'm sure will nod at this, but I find that a particularly odd worldview from people who work in a hospital that daily sees multiple amputees sitting on the edge of the hospital, because you're not allowed to smoke in the hospital grounds, sitting out of the hospital grounds smoking. So, we're standing up on a really high place and looking down on people when we take that approach, I think. So to be fair to healthcare clinicians, they actually do care, and that's why we have this writing reflex we've been talking about. They want to think of something that they can do. And I wonder whether, from where I started with, that's what, maybe in some ways that's how we've engaged people with MI. We've sort of engaged them to think this is something you can do when you're stuck. So clinicians want to fix it. Ta-da! Whenever he gets in a fix, he reaches into his bag of tricks And it seems that MI is often the trick that is being promoted for the choice. You know, going back to what some of our clinicians have said, it gives me something to do when I'm stuck. It's what you should do. Isn't there evidence that says this is how you get people to change? And I guess one of the problems is that we've set people up perhaps to have unrealistic expectations of what will happen when they pull MI out of their bag of tricks after they get stuck. So as trainers, we emphasise meta-analyses and efficacy. We talk about the impact of MI with weight, with drinking, with smoking cessation, with blood pressure. And we mention, but I think we don't focus enough on treatment integrity. So for MI to be effective, the client actually has to experience MI. And some of us were at a conference in San Diego a couple of years ago, and a gentleman called Dean Fixon spoke. And the thing that sort of burned in the back of my brain from that was that you can't actually benefit from a treatment you don't receive. And I wonder if pulling MI out of the bag when you get stuck is MI at all sometimes. Oh, what did I do? I don't want to join guest wireless.
No, just keep talking, I'll fix it.
Thanks. Yep, fixed it. So sometimes I think this is kind of how people see MI. They see it as a trick. You know, that they're a clinician, and if I just tell you back everything that you've told me, then I'm doing MI. And if it were a trick, we could simply tell people what to do. And interestingly, I've actually been asked that. I've had an intern on the maternity ward where I'd done some work engaging a young mum who'd had a near-death experience birthing her beautiful child, and was having significant panic attacks. And they're like, oh, we can't do anything with her, you know, she's so distressed. And I spent some time with her, not a lot of time I'd have to say. And a couple of hours later in the afternoon, I was the duty psychologist on the ward, and this intern bailed me up and she said, oh, Kylie, she's so much better this afternoon. What did you do? What did you say to her? Could you tell me what you said to her? Because I'd like to be able to use that with other people. And I was sort of a bit dumbfounded because it's not a trick. It's a way of being. And, you know, as this guy, you know, you sort of looked at that and went, oh yeah, I relate to that. I see where that comes from. Without compassion, without acceptance, collaboration and evocation, that spirit idea, it isn't motivational interviewing, and it's not something you can just give people a script for. So I guess what I'm saying today is that clinicians can learn MI, and we know that, and there's evidence for that, and they can apply it, and we know that with some of the meta-analyses and the randomised controlled trials that they can have good impact. But how do we encourage clinicians to make that part of the routine way that they work? How do we get Felix to open up his bag and let the good stuff shine all the time? I'm not sure I understand why it has to be something you do just when you get stuck. And having just read the 3rd edition of the motivational interviewing text, I'm really excited about the incorporation of the 4 processes, because I can see now a way of engaging people with using MI, not just for the difficult client, not just for the ambivalent one, not just the one who's not ready to make changes, because it's structuring MI as a way of communicating from engaging at the outset to supporting change through to planning and engaging all the way along. So do I think now that clinicians pull MI out of their bag of tricks where I work? Yeah, I think a lot of them do. And it's definitely a start, but it's a start that perhaps misses the point. So I guess I'm sort of throwing it over to you to continue the conversation about how we get people to move from it being a trick, get people to use it as part of the way that they operate on a daily basis. In a 2005 review, Rubak et al. Found that MI outperforms traditional advice giving. It's strong support for a change to routine care. We've got some policy support in an Australian context from the National Chronic Disease Strategy, which delineates MI as an underpinning skill. Not just what you do when someone gets stuck, but what you do throughout working with someone with a chronic disease. And I think together with the focus on the 4 processes in MI, it's time to move away from the get out of a fix approach. I'll give you a moment to read that, and if you can't see that down the back, it says, frequently people think compassion and love are merely sentimental, and I wish I had the kind of voice that Archbishop Desmond Tutu has. No, they are very demanding. If you are going to be compassionate, be prepared for action. We end our journey with Felix today, and I'm privileged to be talking to a room full of people committed to improving the experience of patients, clients, consumers, whatever language you use in the human services in which you work. Where to from here? I'd make a couple of suggestions, if I may. Practice listening intentionally and with a clear mind. Listen to your own consultations. Participate in observed practice, coaching and feedback. And as trainers, for those of us who are, we can encourage good practice all the time. All the time. Continuing research and how we implement these changes in healthcare service systems. And that's a bit close to my heart, and I'm hoping that I'll launch with that in the next year or so. And to quote directly from a 2001 paper by Karen Emmons and Steve Rolnick, indeed it might be argued that the behaviour change of practitioners is as big a challenge as that of their clients. Toward the end of the third edition of the MI text, I did read it from front to cover and almost back again. Bill and Steve write that MI has ventured out into the world, and they hold the hope that it may contribute to the humanisation of services and conversations about change. We all have a role to play in how we influence the services in which we work and how we are with our clients. So, to steal from what Steve said this morning, get your MI hat on and make it part of your uniform. So I'd love to continue this discussion with you all, and perhaps one day my Felix analogy will no longer be relevant, and I'd celebrate that. And I'd maybe celebrate it with the following words. Felix the cat, the wonderful, wonderful cat, he engages his clients and does his bit, true in his way to MI spirit. Thank you.